Welcome to the Palliative Care Advocacy course, which is one way we're building IAHPC's vision of a world free from health-related suffering. I'm Dr. Catherine Pettis, Senior Advocacy and Partnerships Director of this global organization. This is Module 4, which discusses advocacy for the right to palliative care for older persons, a topic near and dear to my heart as I'm part of the global palliative care movement, as well as the global older persons' rights movement, which is rallying for rights on March 3rd, 2022, We're releasing this module to coincide with the rally and making it freely available to all who are interested on the YouTube channel of IAHPC until May, when it'll return to the fold of the advocacy modules on the IAHPC webpage. I'm using the abbreviations PC for palliative care and OP for older persons throughout. In this lecture, I'll cover learning objectives, barriers, global need, the normative framework supporting the right of palliative care, essential partnerships, and an advocacy checklist with some suggestions. This photo, submitted to the 2021 IAHPC photo contest by one of our members from Greece, was captioned, quote, "At the Pain Management and Palliative Care Center, all doctors speak gently to me. They give me the courage and strength not to give up. I trust them," close quotes. That's the tone of our advocacy for the rights of older persons: courage, strength, gentleness, and never giving up. At the end of this session, participants will be able to discuss global aging trends, the existing protection framework, and protection gaps. Ageism, what it is and how it's a barrier to advocacy and palliative care provision, where IAHPC advocates for the rights of older persons for palliative care, what to advocate for, the role of the independent expert on the rights of older persons, and the open-ended working group on aging, and why the IAHPC participates. First of all, we'll take a look at the demographic situation. You can see that the proportion of the world's population over 65 will nearly double by 2050. The health systems we have now, particularly those in lower and middle income countries, but really everywhere, are not built to take care of an aging population with chronic conditions who live much longer. Very few of us will be fortunate to die in our sleep while we're still healthy and active. The actuarial calculations for that population are at about 10%. The majority of us will have chronic diseases, many of which will last quite a long time, and possibly dementia or other conditions that require palliative care. The pain and suffering associated with these conditions are preventable, but only if the health systems, which include access to medicines and trained human resources, are aligned with population needs. So you can see that the title of this diagram is estimated global need. So this is what we do know, it's just estimated. And this is because there's a dearth of disaggregated data on older persons in most countries. Estimates, which may be low, but this is an average, tell us that adults 70 years or older comprise 40% of the population with palliative care needs globally. This is an estimate because most health systems cut off data collection at age 70. So we don't know about the older or oldest old, those who are most frail and needing palliative care if they have chronic conditions. What we do know is that mortality is still 100% for humans and that people are living longer. We also know that medical training in most countries doesn't include geriatric medicine or palliative care. And this is a state of affairs that cries out for advocacy. The result of this lack of holistic care for older persons means that many of them visit multiple specialists where these exist, adding to financial stress, household stress, and often futile treatments that cause more suffering. Where specialists do not exist, people go undiagnosed, untreated, go to traditional healers, and often present at clinics too late for any effective treatment, but still in need of palliative care, which, if they are lucky, is provided by a local faith-based organization, but rarely by the government. This complex slide about adults, not older adults specifically, is quite self-explanatory, so I encourage you to study it on your own time. But the main takeaway is that cancer accounts for only about 30% of global palliative care need for adults over 20, even though in most people's minds, palliative care is only associated with cancer. It's appropriate for all the conditions shown in the pie chart. Adults suffering from dementia, HIV, heart disease, and cerebrovascular conditions taken together account for an even larger population, which is why IAHPC advocates for integration of palliative care into primary health care and family medicine, as well as capacity building for community health workers who form the connective tissue between the places people get their health care, if they're fortunate enough to have access, and the home, where most will live out their illness with their families. So what are the barriers to access to palliative care for older persons? The basic ones are misconceptions about palliative care and the fact that it's rarely, if ever, included in compulsory curricula of nursing, pharmaceutical, and medical schools, meaning health workers are inadequately trained in palliative care and geriatrics. This showed up clearly in the COVID pandemic. These specialties are associated with low status compared to surgery, anesthesiology, critical care, and internal medicine, for instance. And many societies view aging and dying as naturally painful, and older persons' symptoms and suffering as something they have to bear with, rather than something that can be relieved through good care. Access to the controlled palliative care medicines often necessary to relieve suffering and pain is unduly restricted in many countries. Again, largely because of lack of training in correct prescription and handling of opioids, and lack of treatment for substance use disorder. I covered this in detail in modules 2 and 3 of the course, and primary care, family medicine, and community health workers are under-resourced everywhere, although these are key to bringing services to older persons where they live, whether in their own homes, in nursing facilities, or in prison. Changing this situation requires organized and coordinated advocacy. Before going any further, let's equip ourselves with a basic definition of palliative care, which is further elaborated on the IAHPC website. So palliative care we understand as the active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. It aims to improve the quality of life of patients, their caregivers, and their families. It's not just for cancer, it's for all ages, and it addresses serious health-related suffering in a holistic way for as long as it takes. So for more information, please see the definition on the website. We touched on the barriers to access to palliative care, but what are the barriers to advocacy itself? These are the barriers to being heard. And the primary one is ageism in the healthcare system and in the global health narrative, which focuses on a healthy aging discourse that seems on its face to exclude serious illness, frailty, the need for caregivers, dying, and bereavement, all of which are perceived as failure and shameful conditions to be hidden away and not discussed in public. Yet palliative care supports healthy aging as long as possible by relieving symptoms and assisting caregivers. Ageism underlies the lack of information in disaggregated data about older persons, as I've already mentioned. What isn't counted doesn't count, as we all know. And again, unbalanced drug policies and negative social attitudes towards medical opioids often shut down conversations about essential palliative care medicines for older persons with palliative care needs. And last but not least, shrinking civil society space is something we can only tackle by banding together and joining organizations with similar agendas. One way we overcome the barriers, particularly ageism, is to present a compelling counter-narrative, to lead with beauty and a message of hope. And that's why I talk about the beauty of palliative care, how it relieves suffering, brings joy when symptoms and burdens are lifted, when pain is relieved and caregivers supported. IAHP's vision is a world free from health-related suffering. Imagine that. Too often, advocacy highlights only the problems of terrible deaths, incurable disease, and drugs. A tragic truth for many, of course, but one no one wants to hear about, so they close their ears. We need policymakers to listen with the ears of their hearts. And when those who practice palliative care or have received it advocate by discussing the joy palliative care can bring, how it's about life and not death, how it can spur capacity building and resilience, about the light that comes into families and caregivers when they accompany patients on the last sacred journey, those policymakers' ears start to open. Our advocacy uses evidence and testimony, stories, photos, and videos. As this photo from CanSupport in Delhi shows, the work is beautiful, friendly, and expresses the ethos of neighborliness. I'll talk about the other barriers as we go on. International human rights conventions that are legally binding all emphasize that human rights, including the rights to health, which now acknowledges the right to palliative care, are for everyone. But except for one convention on migrant workers, none of them list age as a reason for not discriminating against someone. As a result, the human rights world often overlooks age discrimination. This lack of specific provisions in human rights law is known as a normative gap. There are now conventions on the rights of the child, of women, of Indigenous persons, persons with disabilities, and so on, but none on older persons, except for the Inter-American Convention on the Rights of Older Persons, which also stipulates a right to palliative care under the right to life and dignity. It says states parties shall take steps to ensure that public and private institutions offer older persons access without discrimination to comprehensive care, including palliative care. There are multiple intergovernmental declarations, such as the Madrid Declaration and various regional instruments, but the work now is to begin drafting and secure ratification of a Convention on the Rights of Older Persons, which will include the right to palliative care as part of the right to the highest attainable standard of health. The current independent expert on the rights of older persons is Dr. Claudia Mahler, a friend and colleague. Independent experts are appointed by the Human Rights Council to examine and report back on a thematic or country-specific perspective. This is an honorary position, and independent experts are not paid. I worked quite closely with Claudia's predecessor, Ms. Rosa Kornfeld-Mate, on the inclusion of palliative care as a right for older persons in her reports to the Human Rights Council and to the General Assembly. Ms. Rosa also issued some press releases and participated in the Latin American Palliative Care Conference at a panel in Santiago, Chile, on the right of older persons to palliative care. This took advocacy, relationship building, and partnership building. To state the obvious, it doesn't happen on its own, and Dr. Mahler will be doing a report soon on the right of older persons to adequate housing, which we will also contribute to, regarding the right to palliative care wherever older persons call home, and a report on the rights of older persons deprived of liberty. So we'll be advocating for the inclusion of palliative care for prisoners. As a result of our advocacy, both with the independent expert and with the NGO Committee on Aging in Geneva, where I served as a secretary for a few years, we were able to participate in efforts to ensure that palliative care was included in a Human Rights Council resolution on older persons approved in October 2021. As all member states, your governments approved this resolution and will approve it at the General Assembly, you can use this text to advocate with your governments. The quote, agreed language, unquote, of this resolution recognizes that older persons face challenges accessing palliative care, and the resolution encourages member states to ensure adequate access for older persons. So please use this. We can visualize our global civil society organizations as twigs in the Advocacy Bundle, which is strong and unbreakable. And this is why IHP supports or joins other organizations such as GARAP, the Global Alliance on the Rights of Older Persons, the IFA, the International Federation on Aging, Help Age International, the NGO Committee on Aging in Geneva, and the International Longevity Alliance. We do that to advocate for achievements such as the Human Rights Council resolution just now, among other things. We build partnerships with civil society and with governments and UN secretariats. None of us can do this work of advocacy at the intergovernmental, national, regional, or local levels without partners. By definition, these civil society organizations work on the entire spectrum of rights for older persons, including the rights to health, employment, participation, housing, social security, gender equality, freedom from violence, and so on. We occupy a very narrow but important niche in the movement as a whole, advocating for palliative care as a way to support healthy aging, as well as to alleviate the suffering older persons all over the world are facing as they approach the end of life. When provided at the time of diagnosis or upstream, as it were, rather than downstream, close to death, palliative care can improve quality of life and help to operationalize the rights the other organizations fight for. With their painful symptoms from chronic diseases relieved and with improved mobility, older persons can participate more actively in employment, in their families, their communities, and the pursuits of their choice for as long as possible. Palliative care also supports caregivers of older persons wherever they live, at home, in a care home, or in a detention facility. As an organization in consultative status with the UN Economic and Social Council, IAHPC participates every year, along with the other accredited organizations that fight for the rights of older persons, in the open-ended working group on aging at the United Nations in New York, which is working to create the political will, as well as the normative and technical elements, for a draft convention on the rights of older persons. We submit a written brief on the topic of the year. This year's topic we wrote on was access to justice for prisoners with palliative care needs, the text of which can be found on our advocacy webpage and in the resources for this module. In 2019, we submitted on the right of older persons to palliative care, since the right to health was one of the guiding questions. And we also hold a side event, usually every year, relating to some aspect of palliative care for older persons. Last year, of course, it was palliative care for older persons during COVID, and we had speakers join from all over the world. This year, we expect to co-host a side event with the Humane Prison Hospice Project. So here's a checklist of just a few things. Join an older person's rights organizations and a palliative care organization to do more advocacy. Become a hospice volunteer if you're retired. Add your service to the WHO Healthy Aging platform. You can log on to that. Encourage your government to subsidize health premiums. Include older persons and persons with disabilities in palliative care policies. Include geriatrics and palliative care in all curricula. Integrate geriatrics and palliative care into primary care and community health worker training. So insurance companies in Rwanda, for instance, subsidize premiums for older persons so they can go to the doctor for prevention, as well as health promotion and treatment before they might need palliative care. And this is just one of many practices bearing good fruit that can be imitated. Work with your ministries of health and social services to ensure that palliative care is subsidized for older persons and persons with disability. Work with your medical, nursing, pharmacy, social work, and faith communities to ensure that palliative care and geriatrics are on their radars. This is a big ask, but remembering the data I gave you at the beginning is absolutely essential to improving quality of life for all older persons. The world is just now recognizing the need to move towards an economy of care. And given the global shortage of caregivers, human resources and health system strengthening are central to this advocacy in this rapidly changing world. So thank you, and please check out the resource list with links and the quiz if you're taking the course for a certificate. And always feel free to contact me for any questions that you might have about this presentation.